Well, good evening, everybody. Today's June 30th, 2021. My name is Jens Chapman, and welcome to our latest edition of our Regional Educational Outlook program, sponsored by the Academy of Orthopedic Surgery and the WSMA, and hosted by our own Washington Orthopaedic Association. I'm so grateful and thankful for you being here, and we have a great program with phenomenal speakers that will continue on the thoughts that have emerged during the last couple of months, which revolve around practice management and how independent orthopedic surgeons can best serve their communities under the influence of large corporations that are sometimes out of state. It also pertains to being employed versus more or less independent physician practitioners in our field. And we have three great speakers for this. We're co-hosted by Dr. Edward Arrington. He's the chairman of the Department of Orthopedic Surgery in Madigan and a professor in the Uniformed Services branch of orthopedic surgery. And he'll take the lead off by discussing the very important part of changing from a very structured program like the military provides towards independent practice, which is what he's done, and the reality check of civilian life versus a previous uniformed life. And nobody better than him to speak about that. Dr. Connor Clevener will join us when he is out of the operating room. He just texted me at Harborview, and pertinent to some of the things that emerged in the recent discussions, he'll talk about what are the true emergencies for orthopedic surgery now. When can we pull the go card with our ORs as we're facing practice restrictions like we're having right now in this heat wave, with a significant elective practice restriction due to a national shortage of type O blood. And last and clearly not least, Dr. Alex Vaccaro. He's probably one of the best known orthopedic surgeons. He sits on our Academy presidential line, and he is the professor and chairman of orthopedic surgery at the ROTHMAN Institute, which is a very unique constellation of private practice and academics together. And depending upon Dr. Clevener's availability in his OR, he'll be second or third. And he's obviously invited as a commentator on any observations that we have. Without much further ado, I welcome our fellow board members. And of course, we are hosting this in part with a strong interest in trying to ask all of you who are orthopedic surgeons in the state of Washington to join our organization, and with that support our regional representation mission. So please do join us. It's fiscally very affordable and very reasonable, and it gives us a unique perspective on interacting with one another to try to make positive changes for our practice. Without much further ado, Dr. Ed Arrington is and here I reveal a clear conflict of interest, hero, and he's been an amazing colleague and partner in the academic scene in Washington State. And as orthopedic surgeon, he's been in the field and in the trenches also of raising the next generation of highly competent and sought after orthopedic surgery colleagues. Dr. Ed Arrington, tell us about orthopedic surgery in the military and how you then transitioned into a civilian life. Thanks for co-hosting this, and thanks for bringing us the Madigan perspective.
Thank you very much, Dr. Chapman, for those kind words. My disclosures are on the Academy's website. Tonight, I really wanted to kind of give you a brief history about Madigan and Madigan orthopedic surgery, and then talk about the current state of combat care for our injured soldiers. Old Fort Lewis General Hospital was originally built in 1943, 88 separate buildings, 1.5 miles of interconnecting hallways built on 120 acres. In a year after it was built, the Army, father of Army neuropsychiatry, Colonel Pat Madigan, died, and the hospital was subsequently renamed Madigan General Hospital. It really had a strategic location supporting returning soldiers, not only from World War II in the Pacific region, but Korea and Vietnam. The new Madigan, the one that you can see if you're driving north and south on I-5 in the South Sound, was built in 1995. Built on another 120 acres of Fort Lewis. It encompassed 1.2 million square feet, has 4 separate buildings interconnected by hallways, has expandable to 500 beds, 14 ORs, 15 radiology suites, and is staffed by about 4,500 active duty civilian and contract workers, and there's about 500 physicians, both staff and trainees. I was asked a question about military orthopedic surgeons and where really military orthopedic surgeons come from. And I just wanted to kind of touch on the fact that people enter the military for a variety of different reasons. Those who end up as military orthopedic surgeons have some kind of an educational commitment usually. And that can be in college where they do ROTC, or they may attend the military academy, or in medical school where they do the health profession scholarship program, which is kind of the ROTC of medical school, or the Uniformed Services University, which is the Armed Forces Medical School. The third way that military orthopedic surgeons can join is to volunteer for service. The training that a military orthopedic surgeon gets is the same as any civilian, an ACGME oversight of all training programs. In the current Army setup, there are 6 military training programs in the Army system, training about 20 residents per year. Some of the medical students can be deferred to a civilian residency, and then they serve their educational commitment after completing their residency. So following residency, those graduates either serve as a general orthopedic surgeon to fulfill their educational commitment, or they go to a fellowship followed by fulfilling their educational commitment. Every trainee will deploy at some point, and usually that deployment can last anywhere from 4.5 to 12 months. Ultimately, all military orthopedic surgeons will transition to a civilian practice. And for those of you who may get the opportunity to have a partner who's a military trainee, know that they will be board certified by the time they come to your location, and they may or may not have a fellowship completed at the time that they join your practice. If you look at Madigan Orthopedic Surgery Residency, we're one of 2 orthopedic surgery residencies in the state of Washington. We have a very collegial relationship with the University of Washington. Our residents rotate both at Harborview and at Seattle Children's with the University of Washington residents. The first Madigan orthopedic graduate was in 1977, and since then we've had over 120 graduates from our program. Every graduate since 2001 has deployed at least once, and our graduates are serving not only in the continental United States, but also around the world. Almost over that time, we've also had over 200 staff, and since 2001, every staff has deployed at least once. By my count, almost 20% of both our staff and graduates are current orthopedic surgeons in the state of Washington. Our present staffing is 10 active duty staff, 2 civilian staff, 12 residents, 6 ortho PAs, 3 interns, and 2 ortho PAs. I really wanted to talk about combat casualty care tonight. And before I can do that, I really think I need to give you a historical perspective on where we're at in terms of combat orthopedic surgery. And I'm going to start really with the Civil War. The Civil War, there were 2.5 million combatants. The weapons that were used were relatively inaccurate and non-lethal, but they caused a lot of lethal wounds. And if you look at the killed in action and those that were injured, that's 1 million out of 2.5, or 40% of all people who participated also were killed or injured. The field hospitals were usually located within about a mile of the battlefield, but they were quickly overrun with injured soldiers. The patients were transported either by stretcher or a horse-drawn carriage to the field hospitals. Head, chest, abdominal wounds were all considered expectant and not treated at the field hospital. Remember, at the start of the Civil War, there were no antibiotics, no sterility, and no anesthesia. This was really, though, the birth of combat orthopedic surgeon, because amputations were done to save lives. Look, moving forward to World War I, there were about 5 million US combatants. The weapons certainly became more accurate and lethal, causing a lot of lethal wounds. And there was some protective gear used, and that would include helmets. The other thing with trench warfare, which occurred in World War I, there was less hand-to-hand kind of combat as there was during the Civil War. The field hospitals remained relatively close to the battlefield and within several miles, and patients were transported either by gurney or stretcher, by vehicle, or even early air transportation. There were some antibiotics at the start of World War I. Sterile ORs were available, and there was some early anesthesia. But there were limited advances in the combat orthopedic surgery. Moving ahead to World War II, there were 16 million US combatants, and about 1 million that were killed, died of wounds, or who were injured. The weapons certainly were a lot more accurate and lethal, and there were a lot of lethal wounds. And there were limited, though, protective gear, which included just the helmets. The field hospitals, again, were immobile and usually within several miles of the battlefield. Patients were carried either on stretchers, on vehicles, by train, by boat, or by air evacuation from the field, from the battlefield to the care level. There were a lot of advances in antibiotics through the middle of the 20th century and advances in anesthesia. Additionally, there were significant advances in orthopedic surgery. And if you look at the Germans, the Künstner nails were instituted during World War II. And in the United States, there were advancements in external fixation, wound debridement, blood replacement, and bone grafting. During the Vietnam War, we saw a couple of transitions of care, specifically because there were a lot of unconventional weapons, unconventional tactics, and usually a lot of limited protective gear. Of those who served, of the almost 9 million who served, there were 250,000 that died of wounds, killed in action, or injured. Those field hospitals, again, remained relatively immobile and were within several miles of the battlefield. But we saw a significant change in the transportation of patients, not only from vehicle and stretcher, but to the use of a helicopter, which really transitioned to care where patients could be moved to an area where they had casualty-specific care, specifically because we could overfly hospitals that may not have had specialty care available. There were advances in combat orthopedic surgery, which included wound debridement, non-operative fracture management, and microvascular surgery. But after the Vietnam War, there was really no advancement in combat care. And most of the care that we provided in the battle or planned battlefield was based on civilian trauma courses and not developed necessarily for combat. Medics were taught not to use tourniquets. There were no hemostatic agents. Remember, we all took ATLS, and there was 2 large bore IVs on all casualties, large volumes of crystalloid fluid resuscitation for shock. We used IM morphine, which was our battlefield analgesia, which was really vintage technology. And there was really no tactical context for the care rendered and no focus on prevention of trauma-related problems, including coagulopathy. At the start of the global war on terrorism, those were the plans in place for medical care. And over the past 20 years, we've had significant advances in our care of injured soldiers. Over the past 20 years, we've had about 6,000 US combatants. Remember, we've seen very, very unconventional weapons, unconventional tactics, and unconventional use of munitions and blasts to include IEDs, which have injured a significant amount of soldiers. Because of that, we've had development of echelons of care. We've also developed treatment algorithms for the care of those patients to include the use of tourniquets, hemostatic dressings, and damage control surgery. If you look at just the injury rate through the middle of the 2000s, especially 2009 through 2011, those who died of wounds were a significant number caused by the IED injuries. And because of this, we've had significant advancements in our combat orthopedic surgery. If we look at the Vietnam War and the global war on terrorism and those who have been combat wounded, which would include those who were killed in action or died of their wounds, 85 to 90% of all combat deaths occurred before a casualty ever reached a military treatment facility. And 3 things jump out at you when you look at a chart like this, and that includes the fact that patients are dying because of hemorrhage from extremity wounds, tension pneumothorax, and airway problems. And cumulatively, we could potentially save an additional 15% of patients with just some institution of care prior to them getting to a military treatment facility. If we look at just those preventable combat deaths, we can see that the fate of those injured is usually in the hands of the frontline medics who get to take care of them. They could exsanguinate from a hemorrhage wound. They could die because of a tension pneumothorax or an airway obstruction. So if a soldier right now makes it to a medical treatment facility in the theater of operations, they have a 96% chance of living. We just have to get them from the battlefield to the medical treatment facility, and that would be with our first line training of our first line medics. John Holcomb looked at a casualty rate, our casualty fatality rate, which is the percentage of injured who died of their wounds. And our current US casualty survival rate in the global war on terrorism is the best in our nation's history at just under 10%. If we look at that in a bar graph, you can see from the Revolutionary War to the Iraq War, a significant drop in the combat deaths as a percentage of all of our casualties. You might say, why? Why is that? Well, I mean, what are we doing better? Well, we've trained our frontline medics that are better trained. We've improved our protective gear, and we've instituted treatment algorithms to include damage control surgery on the battlefield, early use of tourniquets, hemostatic dressings, blood clotting, or whole blood and clotting factors. We also control the air in the theater of operations, so we have shorter evacuation times from the battlefield injury to the forward resuscitative care. If we look just at the body armor, I just want to talk a little bit about this. It includes a Kevlar helmet, protective eyewear, extra neck, shoulder, and groin flaps. And the use of the IBA accounts for a dramatic decrease in those wounding to the torso wounds, which can be lethal, but it's also caused a relative increase in the percentage of extremity wounds over the course of the past 20 years. You might say, well, why do we wear that protective armor? This is a soldier who's on patrol outside of his Humvee. Sniper takes aim, hits him center chest with his body armor on, and that bullet stopped just an inch in the center of his chest away from his heart. If we look at our far forward damage control surgery, we really want to try and avoid the deadly triad: hypothermia, coagulopathy, metabolic acidosis. And how do we do that? Well, we got to stop the bleeding, hyposensitive resuscitation, remove all the contaminants, leave wounds open, and plan a return to the operating room within 24 hours for more resuscitative surgery. We've also had a global or a use of tourniquets, and the liberal use of tourniquets may be the single most significant life-changing and life-saving management that's been instituted over the course of the past 20 years. We certainly know that femoral artery laceration can exsanguinate a patient in 3 to 5 minutes. So that opportunity to apply a tourniquet early on is advantageous for all of our injured soldiers. Every soldier carries at least one combat application tourniquet that can be applied with a single arm. And every soldier is trained that if you don't have a tourniquet, use any means available to stop the bleeding by placing tourniquets on every injured extremity. Well, are they working? Certainly over the past 20 years, we've had near universal Department of Defense acceptance of these. We have a 67% reduction in deaths from extremity hemorrhage. And there's been multiple authors who have documented the overwhelming success, estimated over 1,000 lives saved, lowest incidence of preventable deaths, and the highest casualty survival rate. We've also added the hemostatic dressings and agents. Originally, it was marketed as a powder, but that was problematic for use in the theater. So it was impregnated into gauze bandages called combat gauze. And these are carried by every soldier in the theater. Application of these is usually on the non-extremity injuries, but it can be used on extremities also. We also, as I said, we have the ability to do tactical evacuation because we control the airfield over Southwest Asia. So we have helicopters who can move those patients from the level 1 to the level 2 or 3. In this diagram here on the right-hand side, you can see the different levels of care. And that level 1 is a combat medic. The level 2 is the far forward resuscitative care. And the level 3 in the theater of operations is that fixed immobile combat support hospital or field hospital. If we look at that buddy aid or that level 1 first line medic, those are the ones who are going to certainly help us with preventable deaths by application of a tourniquet, by tension pneumothorax, or an airway. Now, the unfortunate thing is some of those medics sometimes are having to work at night or under hostile fire or with different types of environmental extremes. Once those patients are stabilized, though, they can be air evacuated or ground evacuated to the next higher level of care. That level 2 care is the far forward resuscitative care or a forward surgical team. That surgical team comprises the two general surgeons and one orthopedic surgeon, and it's usually not a fixed facility. It's usually tents, and they're able to move with a maneuver unit, and they provide only the immediate surgical and medical trauma stabilization. Their resuscitative surgical intervention is what we call damage control surgery. There's really x-rays available, but no C-arm, there's no specialty care, and certainly no definitive surgical reconstruction available. When the patients get evacuated from there, it's usually by air evacuation, and that's to the more fixed hospital or that combat support hospital. These have subspecialty care available. There's further surgical and medical stabilization, including in a fixed OR, usually with a C-arm available. They have limited definitive surgical reconstruction available, though, and the air evacuation from there is usually by fixed wing, meaning they're going to fly out of country to the next higher level of care. Currently in Southwest Asia, that next higher level of care is Landstuhl, where all subspecialty care is available, further surgical and medical stabilization is available, and there's definitive surgical intervention and reconstruction available. Once patients are stabilized there, then they're air evacuated back to the U.S. medical centers, of which Madigan is one of those. And there are level 5 U.S. fixed hospitals of major medical centers. There's all subspecialty care is available. There's definitive surgical intervention and reconstruction. At the outset of this current conflict, the U.S. military instituted a prosthetic and advanced rehabilitation called the Center for the Intrepid. They placed 2 of those, one at Walter Reed and one at Brooke Army Medical Center, with the idea being that significant increase in extremity injuries would be concentrated care where those amputees could not only cheer each other on, but could help advance the care of other amputees, up to and including those who might want to redeploy into the theater of operations. So in summary, military orthopedic surgery has advanced some of our amputee and blast injury care. The body armor has clearly changed the injury patterns that we're seeing. Tourniquets are life-saving. Treatment algorithms using best practices have also been very, very practice-changing for us, including the use of whole blood and plasma in the far forward deployment. And to quote Hippocrates, "He who wants to become a surgeon should join the army and follow it." Thank you.
Dr. Arrington, thank you so much. This is a humbling and amazing presentation, and thank you for your work. I'll take 1 or 2 questions from our panelists. I have a single question for you, and that is, as civilians, how can we serve our military in a civilian function to support our orthopedic mission? I remember, and I say it, and I've said it many times, a highlight of my professional life was to get to serve as a civilian orthopedic volunteer surgeon at Landstuhl during one of our conflicts. And I was so amazingly taken by the wounded warriors and the spirit of our injured servicemen and women. So how can we as civilians support our military?
I think that there's 2 things that I would point out. Number 1 is the OTA program that you just mentioned. That's the Visiting Scholars Program at Landstuhl, where visiting U.S. surgeons can get credentialed to go to Landstuhl for 2 to 4 weeks and provide support for the surgeons who are there. The second way would be, as much as I'd like to say that we can handle everything that walks in the front door at Madigan, there are a lot of things that do come in that we are unable to care for above the level of the expertise of the surgeons that we have on staff. And certainly our collegiate relationship with the University of Washington has been great for us to send stuff to Harborview that we really can't take care of. And I think those are the 2 things that come to mind. If you can assist us in taking care of people, and the OTA program of visiting scholars at Landstuhl.
Thank you. Open the question for 1 or 2 questions from our panel. Anybody? Otherwise, thank you for this overview. And in order to not lose time, but please stay on, because the next lecture ties directly into yours. We asked Dr. Connor Clebano, who's an associate professor for orthopedic surgery and sports medicine at the University of Washington, to reflect on, in this day and age, what are the true emergencies? This came up in a different context in one of our previous REOP meetings. What are the true emergencies that we as orthopedic surgeons nowadays have to deal with, so that we can kind of be compliant and be up to date? And Dr. Stephen Cates talked about infections last time, so this is a great segue to that theme also. So we had a great military presentation. What do we have to do in order to treat emergencies that present at any point in time in our ERs, whether it's a level 3 or non-level whatever center, adequately, so that it does not oppose our standards of education and practice, and so it meets your approval, Connor. And thanks for joining us in the OR with your OR gear on.
Yes, thank you. Can you hear me okay?
Yes, indeed.
Okay, great. Let me share my screen here. So Ed, that was a great talk, and we definitely have enjoy having a great relationship with you down there, and love having your residents come up here. They always do an outstanding job. So talk a little bit about more of the civilian side and polytrauma and damage control, and talk a little bit about what we're doing and maybe some of where it came from. So just a quick example to get us started off. This is something that's not uncommon, particularly this time of year. Motorcycle crash. There's shock in the field, mangled at least 1 limb, and a pelvic injury. So this is the image. You can see segmental injuries to the left lower extremity, as well as an open wound in the pelvic girdle. This is the initial AP pelvis. You see that they're at risk, historically, this x-ray with hypotension was a 50% mortality risk. Obviously, we've made one single thing that's changed, I think, that probably has saved lives, and we hope to study this prospectively, is having our paramedics apply these binders in the field. This is the angiogram from this patient. Actually had a truncation of the external iliac, so that limb was completely dysvascular. Team approach we take here, we take everything very seriously from the top to the bottom. Everyone we see is important. This is the better side of me. My back side, the back of my head is more handsome than the front. I'm here with general surgery, vascular surgery, obviously anesthesia. This patient will be going to the ICU. We have, as I said, top to bottom team approach. We take all of this seriously from our dedicated OR staff, technicians, and OR access. And any day we have multiple rooms doing some of this trauma stuff. So with this patient we wanted to stabilize the pelvic ring. We had an open book pelvis. So you notice that we're putting in crest pins here, which is much less common in most blunt force trauma. We usually put these pins in the sciatic buttress and the supraacetabular area. In this case, I pointed out that open groin injury. Getting back to Ed's talk, obviously we see less blast injuries by far in the civilian setting, but it does occur with accidental discharge as well as some civilian terrorism, where the zone of injury will include the groin and you will have a pelvic ring disruption. In this case, we place crest pins in the pelvis to close it down. Here's that open wound in the groin, why we selected these crest pins. Here's the view of the proximal thigh, the femur. Simple femur fracture, but everything's vascular. This is the distal tib fib with the Volz tendons and nerves. Another view of that. Relatively simple fracture, but again, we don't have vascularity here. It's not vascular, so we perform what we call damage control in the civilian setting. So closing down the pelvis with an X-fix, closing and packing wounds, guillotine amputation with packing in it to come back another day. This was the definitive fixation several days later, so we ended up with a complete disarticulation at the hip and then plated the front of the pelvis and a screw in the back. So where did some of this, at least on the civilian side, damage control orthopedics come from? Historically, femoral shaft fracture was recognized in the setting of high energy trauma as a deadly or high morbidity condition. People knew about the marrow and fat emboli to lungs, the development of ARDS, pulmonary embolism, and then treated in traction with clot, pneumonias, and everything that was seen from the 1950s to the 1980s, essentially. The thought was that they were too sick to operate on, so we placed them in traction. Observations clear that this was associated with high morbidity and mortality. Obviously, everybody knows in the late 80s, they did a study, Larry Bone did a study where he looked at if they fixed the femur with less than 24 hours versus greater than 48 hours, if the patient wasn't sick, it didn't really matter. If there was sort of a low energy, isolated femur, it didn't matter. But if they were sick, if they had thorax injury, then nailing the femur actually improved their outcomes, their respiratory complications, as well as their ICU and hospital stay. So we went from too sick to operate to too sick not to operate. And then the concept of early total care came. So everyone was trying to stay up all night fixing everything, thinking that they would have the same effect as what Larry Bone's study showed. So I think we got a little bit too far on the pendulum. We were nailing things in the middle of the night, nailing everything, multiple bones at the same time, no matter how sick the patient was. And they recognized that, maybe this was a little bit too aggressive. Maybe we were being too aggressive with this. The idea came that the first hit of the trauma was a physiologic hit involving both the immune system as well as the cardiovascular system, and that then nailing the femur or doing too much internal fixation led to a second hit phenomenon. And they observed, particularly some of the work out of Germany, looking at too aggressive early treatment, less to worsening of their physiologic condition. But we recognize that some sort of skeletal stability provided benefit for these patients. So this is the concept of damage control orthopedics. to the compromise. Maybe we stabilize them somehow, and whether that's a provisional plate, external fixator traction, and convert to a nail later once they're more stabilized. So it was first coined at Shock Trauma Center. Obviously, it's a naval term historically, the damage control. And so you have a patient like this who has multiple long bone fractures. This patient's in their 60s, not the best heart. You can see the obesity from the soft tissue window. So instead of spending, 6 hours overnight, nailing the femurs and the tibia, that this patient would get external fixators to provide skeletal stabilization, provide more contemporary resuscitative strategies with whole blood. Ed was mentioning, just large bore IVs and pumping people full of saline, and that's advanced and changed over time to a more targeted resuscitation strategy. But, they're having ongoing active bleeding from these fractures. So any amount of skeletal stability is going to help them. Obviously, we know about the benefits of this. You can stabilize the bleeding, stabilize the clot, decrease their pain, and any of these cyclical immune modulators that are pro-inflammatory that are circulating around, we feel like we can potentially affect some of this cycle and prevent that second hit phenomenon by stabilizing this. Clearly, this is a continuum, and there's no hard and fast facts. If you are a referring hospital, and we're, I think, particularly privileged in this region to have referring hospitals that do an excellent job of stabilizing patients, and if they are referred to Harborview, they are, my observation is they're very well packaged up. There's not a lot of delays with people doing things that they're not comfortable with. A lot of provisional stabilization is done appropriately and then transferred over and transferred over quickly. Because we know that the sooner they're transferred over to us, the sooner we can provide our interventions to provide mortality and morbidity benefit. One common example I wanted to just point out from an everyday working example is the concept of providing skeletal stabilization with external fixators. Ideally, you want something stable, but you want something reduced as well. So this is just an example of, you still want the reduction provided. So here's an intra-articular distal pilon fracture. The images on the left show the initial injury films. And on the right was somebody that provided external fixation here. And you can see how the talus is not aligned with the tibia on the AP or lateral view. And you may think, well, okay, that's not the big a deal, if it's not perfectly reduced at this point. But if you notice on the lateral view, that anterior skin is under tension. And in this setting, by the time this gets over to us, we have full thickness eschars on that. So just be mindful if you're stabilizing any distal tibia, whether it's ankle, pilon, distal tibia, to get that talus lined up with the tibial shaft, because it really helps protect that soft tissue. So we went from damage control, and now we've evolved even further to maybe early appropriate care. So if you take a patient like this is a patient of ours that we had when I was a fellow in Baltimore, and you see like this was a partial ejection out of a vehicle. The car rolled over this patient. So clearly this person has multiple life-threatening and obviously limb-threatening injuries. So this is the patient you're going to provide damage control. So guillotine amputations at the level decided by vascularity and ex-fix stabilization of any fractures associated with this. When you're evaluating these kind of patients, it's a team effort with anesthesia as well as the ICU team. We're going to look at the vent settings. Most of these patients are going to be intubated. What are those settings? Are they working hard to maintain the blood gases on these patients? What about the resuscitation? We don't go just based on one hematocrit or one lactate. We're looking for trends. And that trend may change intraoperatively. So you may start out with a lactate of 1.8 or 2, and you say, okay, we're going to nail the femur. But then by the time you're done, 2.5 hours later, 2 hours, depending on how much it takes you, that may have crept up to 4, 4.5, 5. And at that point, you may convert to DCO. So you may start with a plan of early total care and then convert to DCO. And that's okay. One take home for me is that this is a continuum. The comment of a patient is physiologic stable is sort of a misnomer to me in that first 12 hours. you may be actively providing resuscitation to keep that quote unquote stability. So we like to think of this as a dynamic setting. Indications for early total care. Again, this is where people are dynamically trending the opposite way, trending in the good direction. They're maintaining their blood pressure without inotropes. Their ventilation and oxygenation is not a struggle for the anesthetist or the ICU physicians. Their lactate is normalizing or is flat. They're non-coagulopathic, and that's something that is, I think, one of the things on the horizon is being able to measure their coagulopathy of trauma more real time. You know, just getting an INR and waiting for that to come back clearly is an oversimplification of what's going on with their clotting cascade. So where are we? If you have a patient that is, you know, within 24 hours, what can you do for this patient? If they're not sick, based on some of those parameters that I was mentioning, we're going to provide, and our initial strategy is going to be early total care or early appropriate care, people talk about. In that setting, multiple procedures are okay. This has been studied multiple times, and that really is a little bit of a change from damage control, but not back to the early 90s where we did everything. It's not early complete care, it's early appropriate care. So you get into this mindset of, I'm going to stabilize and fix the most important critical things, and then as time goes on, understand how that intervention has affected the patient. One of my mentors, Bob O'Toole at Shock Trauma, has talked a lot about this. This is one review that's a nice one, just to direct you in terms of CME, to look through some of the evolution of this and how it's been evolving. I'd like to comment a little bit about the open tibia, because that's one of the most common civilian extremity injuries. So this is just an example, one of my patients from last summer. So clearly this was a severe type 3 open tibia associated from a motorcycle crash. One thing we harp on a lot is the initial debridement. Been a lot of research, a lot of time spent talking on podiums as to the timing of this. If you have this patient in your ER and your choice is, oh, I better in the middle of the night take this and do a debridement and washout, and then I'll send it to them in the morning, we would prefer you just send it to us. We feel that a delay of 6, 8, 10 hours, 12 hours to do a formal debridement in the light of the morning in the OR lights, we do a better job of repeat washout. So don't feel like you're doing something inappropriate if you have this isolated injury in a stable patient, of sending it to us prior, you know, as opposed to trying to do a debridement prior. You know, if they're a patient that's not stable for transport and they're in the operating room anyway, obviously would advocate for your excellent skills in providing this debridement procedure. This is what not to do. This was a patient referred to us a few years ago. You know, a relatively simple fracture pattern, clearly a little bit of bone loss, but then did an acute plating of the whole lateral side. Clearly there's a medial sided injury here, soft tissue, and then the placement of this plate is a pretty aggressive soft tissue insult for the lateral side. So, and then the patient was held onto for a while waiting for plastics coverage. So this is one I would advocate. When you see this, it's okay to send over, because what happens in this setting is they end up with something like this. So quite a bit of bone loss because of the desiccation and you know, soft tissue stripping of the bone. So a massive resection required, antibiotic spacer, and then a 18-month, 2-year process to do a bone transport. Now I have here just these classic Lizarov style rings. One of the things coming on the horizon for us is intramedullary bone transport. That's been around for a while in the femur. It's getting better in terms of the technology in the tibia. And so I hope that you know, within the next few years, what we see here on the left with these ring fixators will be much less common, and we'll be able to convert more frequently to internal intramedullary transport. So this is just him at 1.5 years. You can see the regrowth. I'm not sure if he's fully consolidated yet, so we're still following him. Obviously, we have really good plastic surgery coverage here. We are eager carpenters, but hesitant gardeners as orthopedic surgeons, and we do need the gardeners, and we do have that. And you can see this is, I believe, that same patient I showed you, just the massive soft tissue coverage needed for limb salvage in some of these patients. So where are we? This is a patient relatively recently transferred from out of state, a 16-year-old ATV versus truck. So he's got a left pneumothorax, an open book pelvis. He's got an axillary artery disruption in his left side, bilateral femur shaft fractures, bilateral clavicle fractures with scapulothoracic disruption, distal radius, knee arthrotomy, patella fractures, and then a bunch of bumps and bruises, etc. So how are we going to address this patient with respect to our concerns for damage control as well as early appropriate care and polytrauma? So the immediate treatment, obviously the general surgeons are going to provide care to the thorax, the airway. We're going to sheet his pelvis. The massive transfusion protocols that are much more contemporary compared to historic. They put in an IR balloon into his left subclavian artery to prevent hemorrhage out from that great vessel, as well as his pelvis fracture was associated with active extravasation from his gluteal system, pretty classic. So we were able to get control of that. The immediate surgeries we did, obviously vascular surgeon revascularized his left upper extremity. I did a clavicle fixation, an acute clavicle fixation. We talk about clavicle, should you fix them, should you not, randomized controlled trials. Here we're doing a clavicle as a part of damage control orthopedics to stabilize that axillary artery repair. I did an inferior plating of the clavicle essentially because that was the exposure that the vascular surgeons provided me. Then did fasciotomies of his arm. I X-fixed his pelvis. I indeed and X-fixed the femur as well as placed some antibiotic, local topical antibiotic beads, X-fixed the right femur, and we splinted his wrist. So this is just, obviously this is not something that happens all the time and probably rarely at your center, but this is what we're doing here for, day in, day out on some of these patients. Lastly, I wanted to show you something and maybe the limits of what damage control orthopedics could be. So this guy was transferred, 18-year-old male from Montana with this crush injury to his pelvis. You see the x-ray on the right, just a devastating injury to the pelvic girdle. But more importantly, you see complete truncation at the bifurcation of the aorta. He'd been crushed by that equipment, and essentially that equipment just slowly crushed him at the level of the aorta. So we went around a lot of times. I'm not going to show you any clinical pictures just because it's a little bit, traumatic maybe, but this is what we ended up doing. So we did a hemicorporectomy to the patient, resected him at the, I believe it was a lower lumbar spine, and he lived and is alive and now is somewhat of a, what's the term now, not the internet, but a social media sensation, and has a channel on YouTube. He also had a through humerus amputation. So he has one functional arm and half a body. So probably the limits of what we can do in terms of damage control. We actually just published this with our general surgeons recently. So on the horizon, couple last slides here. So minimally invasive hemorrhage control is coming to be much more common. ROBOA is the acronym, if you've heard of this before. So it's essentially an internal tourniquet that they can quickly do a cut down in the groin, access the artery, float this balloon up, and then they can decide what level they're going to inflate it depending on where the hemorrhage is occurring. So this is on table, on OR table, relatively quickly to do, and then this can be managed. So they'll inflate the balloon, decrease it slightly, inflate it again. And we had one recently where there was a high velocity ballistic injury to the femur with complete disruption of the iliac artery. And so they were monitoring as we provided external fixation, and vascular team repaired and revascularized the iliac system. They would put it up, put it down, put it up, so they continue to provide inflow to the rest of the trunk. As I said, the other thing that's that I think likely getting influence from the military, as is usual with a lot of medicine, is getting more of the paramedics involved in the acute care in the field. So pelvic binders, we've had much more distributed throughout the paramedic community, as well as potential for antibiotics for open fractures in the field. So there's just a couple things in terms of forward thinking out from the referral center where interventions may benefit patients. So that's just a few thoughts. You know, I didn't know for sure all that you guys would be interested in, but look forward to any questions if you have them, and I appreciate you and thank you for inviting me to talk tonight.
Connor, fantastic job, just like in a great sequence to Ed's great talk, and really helpful, I think, because as I did my recertification recently, a lot of paradigms in my trauma experience have changed. Time will only allow one question. I'll take the prerogative unless one of my fellow panelists wants to edge in. And this goes to Ed and you. Ed mentioned tourniquets. How long are you comfortable keeping one on so that you, if you have to amputate the limb, don't sacrifice more length? And maybe Ed, you can weigh in what you teach your people as well. So Connor, maybe first, and then Ed.
Yeah, from our perspective, we would keep it on as long as you need to prevent hemorrhage. We do take it down when they come in to see if there's any active extravasation, and there's often not. But it's okay to, from our perspective, we would have you keep it on as long as they need it and get the patient to us so we can make that determination. Ed,
same question to Ed.
You?
Yeah, same question to Ed. And add to that, masked trousers. Are they done and out?
I would echo the same thing that Dr. Cleveno just said, that the tourniquet remains on from the point of wounding until they're at a facility that can handle their evaluation. And that can be any length of time.
And in a severely mangled limb, final question, and then we have Dr. Vaccaro going next. Limb salvage versus trying to just external fix and temporize. Assume a seriously ill patient with a single mangled limb. Ed, maybe you go first. If in doubt, limb salvage, external fix, or kind of ablate.
In our deployed environment, I always say that the first person who operates on them is not the person who's going to do their definitive procedure. So for us, it's limb salvage until they get to a definitive place that can provide their care. Connor,
anything to add to that?
Yeah, and I think this is really where experience and expertise helps, because sometimes it may be a salvageable limb, but they're so coagulopathic that limb is not helping them survive the trauma. And so that decision to amputate to keep them alive is made. So, salvage versus amputation is tough because it's not always about whether it's a salvageable limb over the course of 2 years, like that one I showed you, but is what is right for that patient right now.
Super. Thank you both. And on to our third speaker. It's 10:18 p.m. On the East Coast. Dr. Alex Vaccaro is one of the orthopedic surgeons who does not need an introduction, but I will introduce him nonetheless, and I'll abbreviate it in the interest of time. He is, in full disclosure of conflict, an old friend, co-author, and co-investigator. He's a professor and chairman of orthopedic surgery at Thomas Jefferson University, and he's the president of the ROTHMAN Orthopaedic Institute. He's had numerous awards. He's an MD, PhD, MBA. I'm waiting for the JD, Alex. I'm sure you're working on that. Book author, and he's been a thought leader in orthopedics. One of the things that really interested us in general is we talked about multiple practice perspectives, and I said that in the introduction. Independent orthopedics, local, strong integration versus big chains versus even national chains. The announcement by our CEO, Dr. Hudson, on 5/25 kind of added acuity to this, and we will not talk about the negotiations currently ongoing, but he said that there are ongoing discussions with the ROTHMAN Institute. And the ROTHMAN Institute in the spine world and orthopedics has an enigma. I thought nobody better than you, than the president of the ROTHMAN Institute, tell us what is the ROTHMAN model and what has made it so successful. Alex, thank you for staying up so late, and fire away.
Thanks, Shannon. Can you see my screen?
Yes.
So my major conflict is that I'm the president of the ROTHMAN Institute. I'm an Academy board member. And Jens asked me to talk about the ROTHMAN Institute model. And first of all, I'm humbled by Ed and Connor's talks. Thank you. I learn every day. I just thank God I don't do trauma surgery anymore. I just do spinal trauma. So as of Saturday, a newspaper article published in the New York Times noted that 56 of all orthopedic practices are either owned by a hospital or by private equity, which I think is disheartening. I hate to see orthopedic surgeons lose their autonomy. And what we have at the ROTHMAN Institute is an opportunity to stay as an independent single specialty group. And I'll talk about the pros and cons of that. So we started in the 70s. Dick Rothman passed away 2 years ago. Right now, we actually have 212 physicians, and we have sort of a hub and hub model where we're based in Southeast Pennsylvania, but we have relationships in New York, Bergen County, Southeast Pennsylvania, Florida, Western Pennsylvania, and we're discussing a relationship in Seattle at the present time. And we have a typical mission of an orthopedic group. We want to give the best MSK care possible. We're committed to sort of a platform to sort of maintain independence with the traditional values that an orthopedic group would have. So, this slide is a little bit outdated. We have 212 surgeons at the present time. We take care of all of the major professional teams in Southeast Pennsylvania, and we're involved in 50 bundle payment groups at the present time. We cover all the different varieties of orthopedic care. This slide is important. If you look at the bottom in brown, is that this is part of our business acumen. We focus on, you just can't be an entity. You can't be an orthopedic surgeon alone. You need to be supported by non-operative sports medicine, physiatrists, pain management physicians, and so forth. And we all work together as a team. It's a funnel where an orthopedic surgeon treats the right patient at the right time. You are a surgeon. So we look at things called conversion rates. When you go to clinic, you're not a hero if you see 50 patients. If you sign up 6 patients, why don't you only see 6 patients that day for surgery? They can be cared for better by non-operative care. So we sort of have a non-operative operative method. In the last year, we average about 260 to 300 peer review articles a year. We have the #1 publication rate in the country. And in terms of the United States, we're the number 8 funded in research by the NIH. And we really, I think Rothman started the academic prowess by focusing on total joint arthroplasty. And if you look here, they come out with H-index and so forth, the publications, but the Rothman Institute, and we pay our physicians not based on how many surgeries they do. We pay our physicians on their academic mission. And we base that on both clinical quality care, how often they contribute to the peer review literature and so forth. And that's how you get paid. And I always say, if you work at the Rothman Institute and you lecture at the academy, you lecture at your specialty societies, and you publish peer review articles, you will be paid more than someone who just does surgery. So that's our focus. And this is sort of an overview in 2021. Those are our offices. There's offices down in Florida and now in Western Pennsylvania. So as of 2019, we did about 88,000 procedures and see about 900,000 patients a year. And you could see in 1998, there were 6 of us, and we sort of had that sort of philosophy of staying independent, working with healthcare philosophies, and the revenue from 98 to 2019 has increased. Now it's closer to $1 billion in revenue, just focusing on maintaining what we do best, and that's caring for orthopedic processes. So the way we engage, our brand is academic, and I think that's the most important thing. You can have a good clinical machine and take care of patients, but if you don't study what you do, as both Ed and Connor presented, if you don't constantly study, constantly report, keep registries and focus, you're really not contributing to the treatment of orthopedic problems. So we focus on clinical performance, academic engagement, and then everyone has to work hard. Up until you retire, you're taking call, you're covering the emergency room, you're coming in at night. And this is based on the pressures that we see in the markets today. I mean, it is incredible what we need to do. Every year, CMS comes out with new regulations. We're getting pressure on reimbursement. There's more regulations and quality of life. I mean, we want to go home. We want to see our family. And as we said, I remember when Rothman met with me in 1993, when I became an attending, he said out of the 18 surgeons that he worked with, 17 are divorced, many multiple times. And that's just not acceptable in today's paradigm of lifestyle. So we need to have some sort of independence. And if people look at what makes people happy, I always say there's 3 things that make people happy: autonomy, doing what you love, and mastering what you love well. So that's the focus. So the different types of models that we have out there, you have the private practice model, which we support. You have the employment model, which is acceptable to a lot of people. And then you have the hybrid model, where you have part academics, part private practice. One of the biggest problems we had when we had a relationship with the university is the university puts you in an RVU, they recalculate every 3 years. Your services are not as valuable to them, when maybe they want to focus on transplant surgery, maybe they want to focus on cardiac surgery. Maybe you're not paying attention to your case mix, and they sit down with you and they say, listen, you've done 1 million cases this year, but most of them were uninsured. So we, you understand, we just can't pay as much, and you have no autonomy, and you have no ownership. And then you have problems with the people that work with you. We like to sort of control our teams. I mean, we look at clinical integrated networks and building a team around you. And if you have control over that team, you can be much more productive. And the bottom line, if you look at the average revenues, the Academy published last week, the average orthopedic surgeon brings in about 2.6 million in revenues, and the average orthopedic salary is 516,000. Well, where did the other 2 million dollars go? It went to the hospital, it went to the university, because they're more concerned about the technical fees than they are about surgeon reimbursement. So we have to keep that in mind. And if you have ownership, and if you run a good business, you could see in the future, you're not going to make a living by breaking bricks. You're going to make a living by owning your business and presenting patient-facing care that's economical. So you can not only take care of everybody, but you can do so in an economic fashion that decreases patient morbidity. So the number one thing I think with a private model, and most people on this webinar know that, is physician autonomy. You make your decisions. If you're a good business person, if you give good patient care, if you take care of society as a whole, and if you focus on the social determinants of health, and we invest in our communities, you will do well and your corporation will do well. When you invent something, when you develop something, it is yours. It doesn't belong to the university. And you sit as a shareholder, and it's up to you to make sure that works well. So if you look at all the different models, and I've studied all the different models, the federated models is a big movement for those that want to be independent. We have a whole series of doctors that are going to scale on malpractice insurance, on billing, collections, and all the back office models, but they can't expand. They have to stay in their geographic space. They can't advertise. They can't grow the way they want to do. So federation model, and again, I don't want to go into the details of the slide, but it's not as good as an integrated model. Now, private equity is coming in, and I always laugh at the concept of private equity. They're making money off of you, and there's hardly any money left in medicine. 18.7% of GDP is spent on healthcare, which is crazy. If you look at other developed countries, Germany, Switzerland, the countries that do it well, it's 10 to 12%, 5 to 7%. So now you're going to have private equity walk in and take 25% off the top and then control the business aspect. It's against the law for private equity to run the practice of medicine, but why would you want them to run your business? You could have an insurance company come in, but at the end of the day, the insurance companies are concerned about one thing: profits. And those that go into private equity want to have multiple bites of the apple using a scrape model. So that doesn't work either. Or you can align with a healthcare company like HCA or so forth. But again, that's not a liquidity event. And again, you're sort of controlled by the man. So again, something to think about when you're a young orthopedic surgeon about to go out. So at the Rothman Institute, we focus on one thing, our brand, and that's teaching, research, education, and publication. So we compensate for academics, and we have a hub and hub spoke. As we branch off into different regions, all profits stay locally, and we advocate working with the healthcare system, because the healthcare system is what we call, it's the capitalization. It allows us to sort of do what we need to do to make sure that we can take care of the regional healthcare needs, and we're committed to resident and education. Now, this is just the Rothman model. We have 4 partnership criteria. You see a clinical and you see an academic. Clinical for those people that say, listen, I loved my residency, I loved my fellowship, I'm really not into teaching, I'm not into education. You could see how they get paid a lot less than those that say, listen, I want to be a professor, I want to get in an airplane, I want to travel, I want to commit myself to boards. They actually get much more money. And the numbers that you see, just ignore the numbers, but it depends on your insurance mix and so forth. But there's a certain amount of financial productivity that's necessary. You have to be an associate professor to be a partner. You get paid more if you're a professor and so forth. And this is sort of the overview. This is how physicians at the Rothman Institute get paid. Academics are the most important things. You need a total of 204 points. And if you look at the schedule, the vast majority of those points are from academic productivity, which is the brand. And if you look at other people that do that, the Mayo Clinic, MD Anderson, you'll see MD Anderson at Cooper, MD Anderson at the Mayo, and MD Anderson. And they sort of follow the same protocols. They study what they do, they have clinical trials, and they contribute to the literature. Now, once we sit down in a particular region, we have a tripartite mission. We want to have a relationship with the healthcare system. We want to focus on patient population. I'm not talking about bundle payments. I'm not talking about fee for service. I'm talking about looking at the total MSK spend in a region, which can be 20 to 30% of spend on healthcare, and saying, how can we do that cheaper? How can we avoid redundant care, wasted care, fraudulent care, excessive cost care? And then how can we make things better for the actual providers so they can go home earlier and be with their family? So in terms of with our healthcare partners with a particular physician, we focus on passive income, we focus on growth. If you want to be dedicated to academics, we support that. If you want to be an administrator, we support that. If you want to be just a clinician, we support that. And we basically focus through clinical algorithms, value-based care, using the up-to-date technologies and our business philosophy. When it comes to healthcare partners, when we sit down and we're talking to Swedish now, we focus on one thing: centers of excellence, getting rid of wasted care, service line management, and then getting people out of the hospital. I mean, I talk to people in all the different cities and they say, listen, our turnover time is an hour, hour and a half. You shouldn't have more than a 15-minute turnover time in a university setting. If it's more than 15 to 20 minutes, then you're not running that operating room. And that's what we have to move. Basically everything besides tertiary and quaternary care out of a hospital into an ambulatory center, which is so much cheaper. So these are just our larger cases. These are total joint arthroplasties and spine surgeons. And you can see in 2019, the vast majority of those cases are done in healthcare systems, because we partner with healthcare systems because they're dedicated to the community. These are the safety net communities that take care of the poor, that take care of the uninsured, and we are partners with them to make sure those patients get the appropriate care. So number one, it starts with taking care of your staff, getting the right local leadership. And this slide sort of is what we do at every setting. We have a local leadership structure. All the offices are designed the same. We have CINs, clinical integrated networks, that are focused around the physician. Every physician has a clinical assistant, an MA, a nurse practitioner, or a PA, focused on making that physician productive. So if you're a surgeon, you're seeing surgical cases. If you're a non-operative physician, you're seeing non-operative physicians. I'm a spine surgeon, and the last thing I want to see is non-operative spine. And that's all supported by technology. And I am the biggest fan now of telemedicine. 50% of my practice is telemedicine from all across the country. And I'm going to advocate with the legislature to make sure that remains the same. Seeing people in the office post-operatively who don't have to travel for 2 hours is the way to go in the future. It's crazy. In terms of patient access, bring care locally. Set up urgent care models with your clinical pathways. They can see your patients. If they have a problem, do not go to the emergency room. Go to an urgent care center that's hooked up with our algorithms, and use telemedicine. I operate in 3 different hospitals. I do telemedicine rounds. If I operate Monday at one hospital, Tuesday at another hospital 1 hour away, I'm using telemedicine to round the next day. I have one of my clinical nurse practitioners walk around with an iPad, and I could visually see the patient. I could do it around. So every day you're talking to a patient, and we do rounds at the same time. So we invite all the family members to get together. So today we're going to round at 9 a.m. All the family members can come, they can ask questions. So exploiting technology, and give patients the opportunity. If you want to develop a productive clinical practice, every patient has to be seen within 24 hours. You have to have concierge services, VIP programs. You have to have urgent care set up. If you are a busy spine surgeon and your next visit in 3 weeks, you're losing the game. You have to be able to see these patients, and you can see them between cases through telemedicine. If you're traveling to give a lecture at the academy, you can see them in the morning before you go to lectures and so forth. So there's a way of being productive and finishing early, which is key. Everything's based on clinical pathways. So you keep large registries, you study what makes sense, what doesn't make sense, you incorporate that into your electronic medical records, and the surgeons are paid to follow algorithms. Now, this is the practice of medicine, so you could do whatever you want, whatever you think is the best, but you want to be within certain guidelines because certain care products don't make sense. We don't inject stem cells in people's knees. We don't inject stem cells in people's shoulders because we don't see the data to support that. So that would be what I would call wasted care, because there's not money to support that type of practice. And these clinical pathways allow us to decrease the cost of care, decrease length of stay, decrease surgical site infections. Rarely does any patient ever go to a SNF or a rehab center. Everyone is focused to go home the next day. You do a scoliosis operation, we're focused to go home the next day. And if you can't go home the next day, if you have to spend the next day, that's okay. But stay out of a rehab center because it doesn't make any sense. So these are the different protocols we study everything. So optimal clinical pathways, PAT block times, preoperative algorithms that we focus on. In the operating room, we've done studies that if you start a case at 6:15 and do the same case at 8 o'clock in the morning, you will finish that case 23% quicker. Turnover times, as I said before, 14 to 20 minutes. And if the hospital says it can't happen, then you go to a different hospital. So you have to do it. And we use staggered rooms. We're involved in the key elements of every procedure. But to have a surgeon be in one room and spend an hour and a half sitting around is waste. The surgeon's not working to the level of their license. So everything we do is focused on being more efficient. And then the post-operative strategies, the in-hospital strategies, everyone follows. And you have to get everyone to buy in on it. In spinal cord injury, do you give steroids? Do you use braces? Everyone does the same DVT prophylaxis. Everything is sort of standardized. If you have we have 19 spine surgeons. If all 19 spine surgeons did whatever they want to do, then we're no different than anyone else, because now it's going to take time. People are going to make mistakes. So we want to focus on that. And then on discharge, you want to focus on sending them home, getting someone to care for them at home. They do so much better. You decrease readmissions, you decrease ER visits, you decrease infection rates, you decrease DVTs. Sending them to a extra care facility is not the way to go in orthopedics. And this is all based on analytics. And one of the first things that we've done is that we just basically use artificial intelligence to cull disaggregated data to find out who's doing well, who's not doing well. We use remote monitoring. If we see a yellow or red on someone's iPhone that did not walk in the way they should have for total joint arthroplasty, bring them in, make a phone call. If we see a green, we know they're doing well, and we don't have to do that. And all this remote monitoring and technology develops weekly report cards. So we can see exactly what complications we're having, what patients are readmitted. And for each surgeon, and this is an example, each vertical bar is an individual case a particular surgeon has done. So this surgeon can see at the end of the month where every one of his patients went. Did they get home? What did it cost that patient in the operating room to do that procedure? What are the cost outliers, and so forth? And when you see this every week, what happens when you study something? You get better at it. So this particular surgeon with this particular cost, 2 months later, has a graph that looks like this, because now he's studying it every day with big data. And he's like, listen, the other spine surgeon over there is spending $5,000 in an operating room doing a single level TLIF, and this surgeon's doing it for $2,000. Well, why can't you do it for $2,000? It doesn't make any sense. So getting away from that. We went through a 12-year journey through episodes of care. And that's sort of, and I advocate this for everybody. You may be in episodes of care. You may not be in episodes of care. I'll tell you what episodes of care allows you to do. It allows you to see how much money you're spending. And if you do time-driven cost accounting, where you tag every person that touches a patient, so the front desk person, the valet person, the nurse that preps the patient, and you look at their salary and how much time they spend with the patient. And at the end of the day, you know your exact cost. I'm not talking about claim costs. I'm talking about your exact cost. And then you can go to the insurance companies and say, in order for me to make a 6% margin, I need to get paid this. And you get better at it, and you get better at it. The problem with bundle cares, it's a race to the bottom. So it's not the future, but it's a step to population health. And the way we do that is we use artificial intelligence. We have these automated questionnaires that patients answer, and they go through a series of questions. We have 43 medical questions and 15 social questions. And depending on where they fall, it tells me where that patient is going to get admitted. If the patient has complex medical problems, then they have to be optimized before they come to the hospital. So I could bring them and do them in a community hospital or a specialty hospital, or maybe an ASC with a care suite. So you sort of do that. And I'm not talking about the cases that Ed and Connor are taking care of. I'm talking about elective degenerative disease, tumor, and elective infection cases. So you do the right patient in the right facility. And let me tell you something, you're saving a lot of money if you do that. And if you look at, as we walk into a different community, and over time, 2015 to 2020, the blue graph shows all the lower cost facilities, because you really don't have to do cases at a university hospital unless they're a tertiary case or a trauma case. Why wouldn't you not do a total joint arthroplasty in a ambulatory surgical center, same day discharge? It doesn't make any sense to me. If you're an ASA 3 or above, I can understand it, but why not put them in a care suite? The amount of money that you can save. And then you develop networks with preferred providers. You go to the pain management doctors that don't churn the patient with narcotics, that don't churn the patient with injections, that don't repeat physical therapy. You could set them up in home therapy. So you figure out who the right partners are, and you make your own personalized narrow network to save costs, and the patients do better. And then you use remote monitoring, which I think is the best thing, where patients are told preoperatively how to prepare for surgery. They're sent text messages in the hospital to say what to expect. And then the follow-up, it goes over everything. If they have any questions, it's sent to your extended care provider who can look at that so they can follow it. And then they compare it to your data population of patients who've had a similar procedure so they can see how they're doing compared to someone else who had a total joint arthroplasty. And they say, well, listen, even though I don't feel too good, I'm doing exactly as expected. It saves them the phone call and it gives confidence to the patient. So in the last 12 years, we did a series of bundles. And I want you to focus on the fact that it was easy to save money across the board in the bundles because of the excessive amount of money spent in healthcare. And then you develop a gain sharing program, and that money goes right back into reinvesting into your organization, and it goes right back to the physicians that care for these patients. But this slide is really important. If you look at the far left corner, if you go down to far left column, go down to CMS, if you follow that over, you could see in 2018, 2019, we lost money in CMS. So what did the Rothman Institute do? We pulled out of old CMS bundle payments because it is basically designed to show you how to be efficient. But every time you become more efficient, they reset the target price. And then you have the management company that takes 2 to 3% off. So you cannot do well with a bundle payment program after a certain amount of years. And I always laugh when people say, oh, I'm doing great in bundle payments. Well, you're not doing bundle payments right. Because if you're doing bundle payments right, it's a race to the bottom. This is not the way to go in the future. The way to go in the future is if someone needs surgery, they go to the operating room right away. It's not you have to do 6 weeks of that or 7 weeks of that or 3 injections. If they need surgery, they need surgery. If they don't need surgery, they never come to the operating room. And if they don't need surgery, you don't churn them with non-operative care. And that's how you save money. If you look at the graph on the left, orange is bad. That means they're being done in high-cost centers, i.e. universities and tertiary care centers. And then once you sort of institute these programs, it turns blue, which means now they're being done, now they're being discharged home, and it's saving money for the entire healthcare system. Blue in these pictures is the Rothman Institute. And as we move into different areas, you can see 96% of patients are sent home, 1 to 1.5% go to an extended care facility. We decrease the cost of care by about 40%. And that puts us sort of in the top 10% of CMS. Even though we don't participate anymore, we're in the top 10% of CMS. And these graphs just show you, again, we're the blue, and you can decrease readmissions, infection rates, ED visits, and complications, and so forth, which is important. Now, this is just an example. So this is a CMS, and we're the blue line, and we're in the top 4% of the country, and we were losing money because locally they said, okay, they could care less what the group next to us was doing, what the group on the left of us was doing. They just continued to compare yourself to yourself, which makes sense for the government. But once you get to the point where you can't go any lower, what you would do is you would sacrifice quality care for a patient. So it's not the way to go in the future, but it's a great exercise to do that. And then on top of that, you have to make a service organization. We go to the Ritz-Carlton and we have the Ritz-Carlton people come in and tell us, how do you make people feel good about their stay? A comfortable environment, the way you approach them in the front desk, the way you make them feel, the fact that they have immediate access to the jelly beans and our electronic medical records, and you manage your brand on social media. Now remember, social media is a double-edged sword. It's weaponized, it can be manipulated, but it's the way to go in the future, just to make sure you get the message out, because you want to do the, again, like I said, the quadruple aim, the right patient, the right place, the right time, and I say the right price. And when I talk about the right price, I'll get that into a second. You have to decrease the cost of care that's provided by your community. So when we go into a new community, we do 4 things. We assess what is going on in the community. We sit down and talk to the surgeons. How's everything going? We don't go into any community where things are going great. But if someone tells me my turnover time is an hour and a half, I get home at 6 o'clock at night and I'm in one room and I do 2 cases, well, that's a problem. Then we sit down and we plan. We say, listen, is there a way that we can make the quality of life for the orthopedic surgeon and the quality of care better? Then we sort of implement a plan. And then we come in if we can make sort of a business arrangement. We monitor the outcome. And it's usually a 9-month process in how we do that. If you look at the most recent group, we went into Central Jersey to a very successful group. It was called the Trenton Group, right above Princeton, and they were doing great. 2016 was a small group, revenues of 19 million, and you can see in 3 years we almost doubled their revenue. 94% increase in net operating income. We dropped their expenses by 21% and increased their revenues by 51%. And not only that, the surgeons who were surgeons stopped seeing non-surgical cases and started to see surgical cases, and it went right up. So just making care more efficient. The patients appreciated it, and the non-operative physicians appreciated it. So we enhanced call center algorithms. We instituted marketing strategies. We allowed every physician in their group to exercise at the level of their license. If you're a PA, you have to function at the level of a PA. If you're a nurse practitioner, you have to function at the level of the nurse practitioner. And over 3 years, you can see, and the brown line is the cost of care in the community. So we get in, the cost of care at this particular facility was extremely expensive. And the goal was to decrease the cost of care commensurate with the care in that particular market. You're not making any money in any market if you're more expensive than your competitor. So you got to make it cheaper. So I think from this perspective, I'm a big advocate, as you can see, with being independent, not independent as a clinician, but independent as an academic clinician. And every location is a separate autonomous market. Some say to me, I don't want to do any academics. And then you work around, okay, well, if you're not going to do academics, but we still have to study the outcomes and the quality and the cost, and we have to make it more efficient, because at the end of the day, it's all about the patient, making their experience better and making the outcomes better. And it'll build resiliency and decrease burnout among the physicians that participate in the process. Thank you.
Alex, outstanding. We're a little bit behind time, but this is well worth it. A couple of things. So first of all, a treasure trove of things. We can't address it all. And I know it's bedtime for you, or past bedtime, because as we know from that great video, A Day in the Life of Alex Vaccaro, you get up at 3:30 a.m. and do your first morning workout. So one question that came from Chet Donnelly, I'm just reading from the ample chats, is if you have this 24-hour scene policy, this sounds nice, but how do you handle it when patients just cancel and don't show up? If it make it too easy to get to a doctor, how do you prevent that from getting abused?
It happens all the time. You probably have a 15 to 20% call out rate. So you handle it like an airline. If you have capacity for 10, you book 14, you end up getting 9. So you handle like it, and the airline industry has done it all along. They overbook. That's why occasionally, Jens, you and I were sitting in a room, we say, we're booked tonight, we'll give you an extra $150 if you give up your ticket. You do the same thing in orthopedic care. The last thing an orthopedic surgeon wants to do is sit around and do nothing. There's only 2 things that don't exist in an orthopedic surgeon's mind: unicorns and the fact that they're not busy enough or making enough money.
Well done. Then a second question, then we'll really come to a close as promised. Underserved patients. So as is the case in Philadelphia, we have a very large population of homeless and of drug abusing patients. And some of them have extremely long lengths of stay. So how do you handle that when you have a mission in your hospital system? And how do you equate that with the value proposition to kind of get averaged?
So that's a great question. So I'll give you an example. Thomas Jefferson University. Every university is a safety net. Every university has managed care programs for the underinsured and Medicaid. I want you to understand one thing. The hospital doesn't lose money taking care of a Medicare patient. You lose money as an orthopedic surgeon. So don't ever get fooled by the fact that you're taking care of these patients. So what you have to do is you have to work on an arrangement with the hospital that you get your costs covered. You want to take care of the poor, you want to take care of the underinsured, but you don't have to be the sucker like I was for years, operating and getting paid nothing, but incurring the legal costs. So you work out a relationship with your local hub and hub university or hospital where you get compensated for caring for the uninsured.
Alex, this is Neil Shonner. Can you hear me?
Hey, Neil, how are you?
Oh, I'm doing good, buddy. I just wanted to comment on you before you, because you got to get to bed before that workout tomorrow.
Thank God.
God loving the NFL. But there are some people on the line who have a familiarity with the things you're talking about. You were talking about the parameters of population health. You were talking about eliminating toxic variation. You were talking about enhancing patient engagement. And you were also talking about something that we did original publications in predictive analytics on: the right patient, the right procedure at the right time. I want to congratulate you. This was a wonderful presentation tonight. I thank you for being open to speaking with us, and appreciate
And Neil, you only get younger looking. Neil was a fellow with me in 1992, right?
Yeah,
1992.
you were my junior resident, but
And
you know,
you're getting
the
younger
picture
looking
you've
every
got
day.
up, you've got a picture up from your high school years. That's cheating, man.
That was ninth grade. Ninth grade. Jens asked me for my ninth grade picture.
God bless and thank you.
Thanks.
So we'll sign off, conclude for a great evening. Thank you all for your interest. Please, as orthopedic surgeons in Washington State, join the WSOA. And we're going to go on a summer hiatus, July and August, and restart in September. Thank you much for SSF and for the WSOA board, for our speakers tonight, and the lovely Emily Jones for her everlasting care. Alex, you're awesome. And we'll look forward to the 3:30 a.m. workout. Okay, man?
For all the speakers, God bless. You did great work tonight. Jens, thank you.
Thank you. Take care.